Welcome to the lecture on the neck. My name is Carlos Andres Suarez-Quian, and I'll be the narrator of this lecture. Look at this incredible lithograph by Botticelli, made after a dissection by Squancarello in 1837. To enhance your ability to observe different structures, I colorized the lithograph. It is as anatomically correct as anything available today. Yet observe the human features in the drawing. The gaze of the model, almost as if they were still alive. I sometimes wonder if the artistic features and human qualities presented in these dissections from the previous centuries was the author's way of telling us that performing anatomical dissections was a way of examining our presence as a participant in the great experiment known as nature. Let's begin the lecture. The functions of the neck are listed here. It must connect the head to the rest of you. It is an important conduit for vessels, nerves, and also for the airway and the alimentary canal. And finally, it contains important endocrine organs that help to regulate our metabolism. But what is often forgotten is that the neck also serves as an area to wear adornment, or important indication of rank. But aside from these interesting facts, why must we study the neck? And the answer lies in these images. In Figure A, the left, we see a CT image of a patient's neck, and in Figure B, we see a PET scan of that patient. It is not uncommon to have a patient with a lump in the neck. The reason for this is that metastatic carcinoma to the neck is the most common head and neck cancer, and 3 to 5% come back as squamous cell carcinoma or undifferentiated tumors. Compare the right side of the CT with the left side, and the evidence that this is undifferentiated tumor is highly metabolically active. These findings of poorly differentiated cells is highly suspicious of a malignancy. Lumps in the neck can lead to poor prognosis, in part because of all the structures these very aggressive cancers can impair. The second reason is the image on the right, the individual lying in the ER with a knife in the neck. Trauma to the neck is not rare and represents 5 to 10% of all trauma. But as we will learn, multiple structures can be injured, and mortality as high as 11% has been reported. Specifically, if the trauma is to the root of the neck. Remember, the pleura and lung reach the root of the neck. Hence, any stabbing injury to the root of the neck may result in damage to the pleura, resulting in a life-threatening situation. Here, for example, is a chest film revealing a large right-sided opacity representing extrapleural blood, consistent with the right-sided superior mediastinal hematoma, a result of a stabbing injury. Having described the two main clinically relevant issues of the neck, mainly metastatic tumors and trauma, the objectives to appreciate in this lecture become obvious. You must be able to describe in detail the structures of the neck relevant to these two clinical scenarios that are listed here. Just deep to the skin of the neck lies a paper-thin muscle known as the platysma. The muscle lies completely within the superficial fascia of the neck and is found simply by removing the skin of the neck. Although in the neck, the muscle is truly a muscle of facial expression, and as such is innervated by a nerve responsible for innervating the muscles of facial expression, the facial nerve or cranial nerve 7. We use this muscle when we grimace, as the individual is indicating in the image. Given that this muscle is innervated by cranial nerve 7, it is clear that paralysis of this muscle can ensue when a branch of this nerve is damaged, and what happens is that the skin falls away from the neck in slack folds. This must happen because the platysma is attached to the skin and helps grant support to the skin. Removing this support results in the falling away of the skin. Indeed, because of this relationship, during surgical dissection of the neck, extra care is necessary to preserve the cervical branch of the facial nerve. And when suturing wounds of the neck, unless surgeons carefully suture the skin and edges of the platysma, the skin will be distracted by the contracting muscle fibers and a broad, ugly scar may develop. To demonstrate the importance of the platysma in maintaining youthful appearance, let's examine the results of what a plastic surgeon could achieve by performing a facelift. The images show a patient before and after the results of a facelift only. I think it is clear that the face of the patient does indeed appear younger. Now examine the appearance of the same patient, but demonstrating the appearance as both the face and the neck skin underwent a lift. It is difficult to argue that the patient does not look significantly younger in the later image. What these images highlight is that the appearance of the neck does contribute to the overall look, and the integrity of the surface of the neck is determined in large part by the healthy appearance of the platysma. The structure that we encounter next after reflecting the platysma is the cervical plexus. These nerves represent the ventral rami of C1 to C4 and are strictly cutaneous. That is, they are only sensory. They do not innervate any muscles. Their function is simply to receive sensation from the areas they serve, namely the dermatomes of the neck. Whenever you receive a pleasing neck rub, these are the nerves sending the sensation back to your conscious self. A schematic of the cervical plexus is now demonstrated in the slide. The names of the 4 nerves are listed here. All these nerves may be readily found within the superficial fascia just deep to the platysma. As mentioned earlier, the dermatomes served by the nerves of the cervical plexus are only found in the neck. Sensation from the front of the face is done by branches of the trigeminal nerve, the details of which I will present in a subsequent lecture. And by recognizing that the nerves emerge within a relatively small area, just posterior to the posterior border of the sternocleidomastoid, anesthesiologists can exploit this knowledge when large surface areas of the neck need to be anesthetized. Such a scenario may ensue following an automobile accident, for example, when a patient's head has gone through the windshield and sustained lacerations. Introducing the anesthetic to the area indicated by the tip of the needle can bring the desired results to then begin the process of suturing the traumatized area. Anesthetizing the back of the neck uses a similar strategy. Note, however, that unlike the front of the face, served by a cranial nerve, the back of the head is served by a cervical nerve, in this case C2, the great occipital nerve. And unlike the near surface location of the cervical plexus, however, C2 can only be anesthetized by delivering the anesthetic at the point where it is in close contact to the transverse process of the cervical vertebrae. Anesthesiologists have found that this area can be found by introducing a needle just posterior to the mastoid process, following a line posterior to the sternocleidomastoid. But in this case, much deeper than at the plane where the cervical plexus is found. This procedure is used for a carotid endarterectomy and in removal of cervical lymph nodes. Whenever one thinks of delivering a cervical anesthetic, however, one must also consider what other nerves are present near the cervical plexus, where the anesthetic will be delivered. Let's look again at the schematic of the cervical plexus, but now fill in the missing nerves. Just deep to the cervical plexus is a phrenic nerve, colorized in red and emerging from C3, C4, and C5. The phrenic nerve is required for us to breathe. It would not be prudent to consider administering a local anesthetic to a patient that might be suspected of suffering from respiratory distress. The anesthetic may also migrate to the phrenic nerve, paralyzing one side of the diaphragm and exacerbating the respiratory distress of the individual. The second nerve that can become involved during cervical anesthesia is the spinal accessory nerve, colorized in green. This nerve is motor to the sternocleidomastoid and the trapezius. If the anesthesia involves this nerve, the patient may suffer transient paralysis of the trapezius and lose the ability to shrug their shoulder on the affected side. A summary of what I have just stated is not presented in this slide. The movie can be stopped for you to review these points. We finish with the cutaneous structures of the neck by looking at the location of the superficial veins. Expect variations, but generally there are two veins that are mostly consistent in their location: the external jugular vein and the anterior jugular vein. The former is formed from the posterior auricular vein and the retromandibular veins. The external jugular vein then courses superficial to the sternocleidomastoid muscle and will drain into the subclavian vein. This is the vein that commonly pops out in a patient's neck when they're experiencing right heart pathology. The formation of the anterior jugular vein is much less consistent and is mostly from the coalesce of veins under the chin. We now move to the discussion of the fascia of the neck, and what you should appreciate already, simply from your own experiences, is that the contents of the neck do not move freely within the neck, but instead are kept mostly in place by connective tissue fascia. The deep fascia of the neck is hard to see in a neck cross-section as shown in this slide and at the magnification presented. Nevertheless, it is there and is part of the reason that the neck cross-section appears so compartmentalized. The fascia of the neck is shown in a schematic in the slide and is composed of 5 separate cylindrical connective tissue sleeves, similar to nesting pots as indicated in the image. The 5 sleeves include the investing fascia, the prevertebral fascia, the pretracheal fascia, and the 2 carotid sheaths. The deep fascia of the neck, as well as deep fascia in other parts of the body, serves as the retaining barrier and helps prevent the spread of infectious material throughout the body. Take a look at the prevertebral fascia and note that there is a gap anterior to the vertebral body. This gap is real and extends from the base of the skull all the way to the thorax. This space consists of what has been called the danger zone between the 2 layers. An infection within this space can travel unimpeded between the base of the skull to the thorax. Images A to C indicate the presence of a retropharyngeal abscess that invaded the prevertebral space. Note the location of the abscess in the retropharyngeal space in the CT image in A and the spread of the abscess into the prevertebral space as shown in the MRI in B. It appears that the patient's neck is bent anteriorly from the abscess. After treatment, C, the patient has gained a more normal posture, but the bones of the vertebral bodies have mostly disappeared. We now move to discuss the triangles of the neck. Anatomists have long broken down the neck into triangles to try and compartmentalize the information of all the structures found in the neck into more manageable bits of information. I will do this now. Initially, we can think of the neck as consisting of 4 triangles, 2 on each side of the midline of the neck. These 2 triangles represent an anterior triangle and a posterior triangle. The specific boundaries of these triangles are shown in the slide. It is not necessary to memorize these boundaries. They are mentioned here simply to give a general organization to the neck and to have you appreciate what has become convention in anatomical speak. Anterior to the sternocleidomastoid, you are in the anterior part of the neck, whereas being posterior to the sternocleidomastoid, one is located in the posterior triangle. The posterior triangle ends at the anterior border of the trapezius. The clavicle and the mandible also contribute borders to the posterior and anterior triangles, respectively. Let's now look at the specific named subtriangles of the neck and understand why they are called these names. Look at the image and see the location of the submandibular triangle. It is just below the mandible, hence its very apropos name. In this triangle, we find a large salivary gland, the submandibular gland. There are also lymph nodes, the lingual and facial arteries, and their corresponding veins, and the hypoglossal nerve. The carotid triangle is located just anterior to the sternocleidomastoid. Importantly, it is where you feel the pulse of the external carotid artery. The thyroid gland can extend to this region. Arteries and veins of this triangle include the ascending pharyngeal, lingual, occipital, and facial arteries. The hypoglossal nerve also extends to this triangle. Indeed, realize that a particular structure may inhabit more than one triangle, but generally the triangle will be named for a prominent feature or for a vital content. The muscular triangle is the site for muscles that move the skeleton of the neck. We will spend much more detail later on these structures. The last subtriangle of the anterior triangle is the submental triangle. It is a location for lymph nodes and veins, but its name is derived from the common practice of rubbing our chins when experiencing deep thoughts. Think of Rodin's sculpture, The Thinker. Moving to the posterior subtriangles, we see the location of the occipital triangle, located in the back of the posterior triangle, hence its name. Occiput means towards the back. It is here where we will find the spinal accessory nerve and other less prominent nerves. The lower portion of the posterior triangle is known as the subclavian triangle. Here we find the subclavian artery and the emergence of the trunks of the brachial plexus. Understand that trauma to this area can and often leads to serious consequences, sometimes even death. Let's now move to the muscles found in the neck. 2 main muscles help define the triangles of the neck, and these are muscles that we use every day moving our heads. First, the sternocleidomastoid. It extends from the mastoid process, that hard lump behind our ears, to our sternum and the clavicle, hence its name. We use this muscle when we turn our heads to the opposite side. Try it now. Turn your head to the left and notice that it is the sternocleidomastoid on the right side of the neck that contracts. When both muscles work together, we extend our heads to look at the sky. The second major muscle that we must consider is the trapezius. Its anterior border forms the posterior border of the posterior triangle of the neck. Shrug your shoulders now. This is the principal muscle we use to shrug our shoulders. Both muscles, the sternocleidomastoid and the trapezius, are innervated by the spinal accessory nerve, cranial nerve 11. After reflecting the sternocleidomastoid and trapezius, we find muscles making up the floor of the posterior triangle of the neck. These muscles function mainly for lateral flexion of the neck and assist with respiration. The space between the scalene anterior and medius is known as the interscalene triangle, and is precisely where the trunks of the brachial plexus and the subclavian artery emerge into the neck. Compromising the space by a cervical rib can lead to a condition known as scalenus anticus syndrome, in which the blood supply to the affected upper limb is compromised. If not relieved, the patient may ultimately need their arm amputated due to necrosis. And here's the most dramatic scalenus anticus syndrome image that I've ever seen. It was published in the 1940 Annals of Surgery. It is inconceivable that someone would survive this level of gangrene. This individual had bilateral cervical ribs, which ultimately impinge on the subclavian artery, sending blood supply to the forearm. We now look at the muscles found directly anterior to the cervical vertebrae, the prevertebral muscles. Their names are shown in the slide. These muscles help to flex the head and neck. The next set of muscles we must consider are the suprahyoid and the infrahyoid muscles. These are muscles that are located above and below the hyoid bone, a small bone in our neck that does not exhibit any bony articulation. Look at the model. The thyroid cartilage represents the Adam's apple. Just above the thyroid cartilage is the hyoid bone. The hyoid bone is connected to the thyroid cartilage by a thyrohyoid membrane that is not present in the slide. Hence, any muscles that move the hyoid bone will also move the thyroid cartilage and all associated structures. These movements are caused by the muscles we will discuss now. Let's look first at the infrahyoid muscles, or strap muscles as they are called, because they resemble an old leather barber strap used to sharpen a straight razor. There are 4 muscles in this category, and they're known as the omohyoid, the sternothyroid, the sternohyoid, and the thyrohyoid. The suffix of the name refers to the distal attachment of the muscles. The prefix indicates the proximal attachment of the muscles. Thus, the omohyoid attaches from the shoulder, omo, to the hyoid bone, whereas the sternothyroid extends from the sternum to the thyroid cartilage. All the muscles have a logical terminology to their name, albeit the terms are in Latin. Based on their location, all the muscles depress the hyoid bone, an event that occurs after we swallow and raise the larynx to avoid choking. We will discuss the mechanism of swallowing in another lecture. The muscles are mostly innervated by the ansa cervicalis, although the thyroid muscle is independently innervated by the C1 fibers, a distinct branch from the ansa. There are also 4 muscles that make up the suprahyoid group, but only 3 can be observed initially. These three include the mylohyoid, the muscle that makes up the floor of the mouth, the digastric, a muscle that has two bellies, a posterior and an anterior, hence its name, and the stylohyoid. These muscles are expected raise the hyoid bone during swallowing. The innervation of these muscles is somewhat more complicated than for the infrahyoid muscles. The stylohyoid and the posterior belly of the digastric are innervated by the facial nerve. The anterior belly of the digastric and the mylohyoid are innervated by the nerve to the mylohyoid, a branch of the inferior alveolar nerve, a branch of the trigeminal nerve. These details will be discussed later. The fourth suprahyoid muscle is found when the mandible and head are bisected to observe the medial view of the head. This muscle is the geniohyoid and sits just above the mylohyoid. The geniohyoid extends from the genu of the mandible, that is, the bend of the mandible, to the hyoid bone. The muscle is innervated by C1 fibers traveling with the hypoglossal nerve. We have now reached the part of the lecture where we will discuss the nerves found in the neck. These descriptions tend to be overwhelming when students first hear them. Please bear with me. We will continue to see these nerves over and over again, and much of what I present will be repeated. The first nerve we encounter is the vagus, or the wanderer, as the name implies. The nerve emerges from the jugular foramen and descends within the carotid sheath, behind and between the internal jugular vein and internal common carotid arteries. The nerve will give off various branches, including the auricular and the pharyngeal plexus. The auricular is sensory to a small area of the external ear. The pharyngeal branch will be motor to muscles involved in swallowing. We will discuss these details later. The next major branch emerging from the vagus is the superior laryngeal nerve. To see this branch, we need to look at the vagus from behind, and is shown in the image. Soon after the vagus exits the jugular foramen, a large superior laryngeal branch emerges that will then split into an internal and external laryngeal nerve. We now look at the continuation of these two branches of the superior laryngeal nerve from the front. The internal laryngeal nerve will be sensory to the mucosa above the vocal cords. This is the nerve that is irritated when we need to cough. The external laryngeal nerve is motor to one muscle, the cricothyroid muscle. Again, details will follow. The vagus continues into the thorax on the left side and will give rise to a left recurrent laryngeal nerve. It is called recurrent because it returns from whence it came. On the right side, the right recurrent does not make it to the thorax, but it too recurs back to the larynx. Both nerves provide sensory below the vocal cords and to all the intrinsic muscles of the larynx except the two cricothyroid muscles. Working backwards, let's discuss the ninth cranial nerve, the glossopharyngeal nerve. Looking again at the back of the neck, this nerve also emerges from the cranium via the jugular foramen, and it immediately gives rise to a branch to one muscle, the stylopharyngeus. The nerve then turns anteriorly, where it will send sensory branches to the posterior aspect of the tongue. We will discuss additional details of this nerve in subsequent regions of the head and neck. Because of its deep location, The glossopharyngeal nerve is rarely injured. However, there is one condition called Eagle syndrome in which injury to an elongated styloid process may impact the glossopharyngeal nerve on the damaged side. This is a colorized reconstruction of an MRI demonstrating an exceedingly long stylus process. These elongated styloid processes are more readily prone to injury, and if the process is broken off, it may impact the functions regulated by the glossopharyngeal nerve. Some of these functions are listed in the slide. Along with cranial nerves 9 and 10, the spinal accessory nerve, cranial nerve 11, also exits the cranium via the jugular foramen. This nerve is motor to the sternocleidomastoid, reflected here, and the trapezius. Injury to the nerve may result in the condition known as torticollis, in which the head is permanently turned to the side of the injury. Remember, the sternocleidomastoid turns the head to the contralateral side. In the baby, it is the left side that is damaged. The next nerve is the hypoglossal nerve, cranial nerve 12. This nerve emerges from its own foramen from the cranium and travels to the tongue, where it will be motor to all the intrinsic and extrinsic muscles of the tongue except one. Details to follow. The ansa cervicalis we encountered before, and it's the part of the cervical plexus that innervates 3 of the strap muscles. Ansa simply means loop. Hence, ansa cervicalis refers to the loop of the neck and is formed from branches of the cervical plexus. And here is the schematic of the ansa cervicalis. Note that the superior root is from C1. Ventral rami from C1 piggyback onto the hypoglossal nerve and travel with it, but do not make the mistake to think they are part of the nerve. Ventral roots from C2 and C3 join to form the inferior root of the ansa cervicalis. The phrenic nerve also arises from the cervical nerves, specifically C3, C4, and C5. The nerve sits anterior to the scalenus anterior, and remember, it is at risk when cervical plexus anesthesia is performed. The nerve travels to the diaphragm to innervate it and allow us to breathe. As mentioned previously, the trunks of the brachial plexus emerge from within the interscalene triangle. The next set of nerves in the neck to consider are the sympathetic trunks. While the rising trunks are sometimes difficult to see in a dissection, the superior cervical ganglia tend to be quite prominent. These trunks represent second-order neurons that exit the spinal cord from segments C8 to T1, travel upwards in the neck, then synapse at the superior cervical ganglion. Remember, we're discussing the autonomic pathway, which by definition requires a pre and a post synaptic fiber. And for the sympathetic pathway, the nerves that will reach the head all exit from thoracic vertebral levels. This diagram also introduces the concept of a sympathetic nerve damage in the neck, leading to Horner syndrome. One of the symptoms of this syndrome is ptosis, or drooping eyelid, indicated by the double red arrows. The mechanism of why this will happen will be discussed later with the orbit, but note, Horner syndrome can result from various causes. The common theme is damage to the sympathetic pathway leading up to the head. We now move to discuss the arteries of the neck. Recall that all blood supply reaching the head ultimately arises from the three main branches from the aortic arch. On the right side, we see the brachiocephalic artery, and on the left side, we see the left common carotid and the left subclavian artery. The brachiocephalic artery will divide into the right common carotid artery and the right subclavian artery. Both the common carotid arteries and the subclavian arteries on both sides provide blood to the head that must first travel via the neck. Look at this dissection of the left common carotid artery, but it could serve for the right common carotid as well. The common carotid artery will split into an external carotid artery and an internal carotid artery. The latter will continue into the head and provide blood supply to it, but will not send any branches to the neck. In contrast, the external carotid artery will send numerous arterial branches to the neck. And the branches emerging from the external carotid artery in the neck are demonstrated in this slide. I will not describe them here, but you are responsible for learning their names and the route they take to their final destinations. Importantly, however, learn how to detect the carotid pulse just anterior to the sternocleidomastoid. The other main vessel from which we receive blood to our head is the subclavian artery. As mentioned previously, the right subclavian emerges from the brachiocephalic and the left emerges directly from the aorta. Prior to entering the scalene triangle, an important artery emerges on both the subclavian arteries. The vertebral artery. The classic mnemonic to remember the branches of the subclavian artery is vitamin C. The V stands for vertebral artery. Additional branches to the neck emerge from the thyrocervical trunk and the costocervical trunk, not shown. These branches are of clinical relevance to the otolaryngologist because they may need to tie them off during certain surgical procedures. The proximity of vessels from these trunks to nerves we discussed previously and the possibility of injuring these nerves becomes the reason for the clinical relevance. The subclavian pulse can be felt where the artery approaches the surface, just distal to the scalene triangle, midpoint of the clavicle. Examine the pulse on yourself now. Although we will examine the blood supply to the brain in more detail later, understand how blood flow from the subclavian and the carotid arteries enters the cranium and ultimately supplies the brain. The common carotid arteries will give rise to the internal carotid in the neck, and this artery enters the cranium at the carotid canal. Blood from the subclavian enters the vertebral artery, and this artery enters the cranium via the foramen magnum and joins the contralateral vertebral artery to become the basilar artery. Branches from the basilar and internal carotid arteries will form a circle, the circle of Willis, that will supply blood to the brain. Look at this dissection of the circle of Willis. Understanding the areas of the brain supplied by branches from this circle helps to understand how deficits result in patients who suffer vascular accidents or strokes. The details of these vessels will be provided later when we dissect the brain. If we cover the arteries of the neck, then we must also cover the veins of the neck, but these are straightforward. If you know the arteries, you know the veins. The locations of certain veins, however, are important to know, especially when initiating a central line to deliver large volumes of fluid to a patient. For example, a burn patient who tends to be severely dehydrated. One such procedure is known as introducing a central line, and the vein chosen for this purpose tends to be the subclavian vein. Stop the presentation and read how this procedure is performed. Read also the potential complications that may result from performing such a procedure, specifically because of the anatomy we have discussed. Yes, a hemothorax is a potentiality, and patients have died following the incorrect placement of a central line. Because of the life-threatening difficulties that can develop from the placement of a central line, modern methods include the insertion of a peripherally inserted central catheter, or PICC line. The advantages of using one versus the other are listed in the slide. Stop the presentation if you wish to learn about the two major possibilities of replacing fluids to a patient who needs it. Having covered arteries and veins, the next set of vessels we must consider are the lymphatics. In general, lymph drainage in the neck occurs as a network of specific and localized areas, but we will not be discussing those areas in this presentation. That is not to say that lymph drainage is not important, because it is, and understanding it yields important clues as to the outcomes of disease. But knowing the lymph drainage of the neck is truly beyond the scope of this course, and it's an important area for otolaryngologists to know. Suffices to know that superficial cervical lymph nodes lie along the external jugular vein. You may remember your physician feeling for these when your parents took you as a child to the doctor's office after complaining of a sore throat. The superficial nodes will drain to the deep cervical nodes, located within and around the carotid sheath. Understand that anything that drains to the superficial lymph nodes will ultimately drain to the deep lymph nodes, and the vast lymph drainage of the neck may account for why so many tumors can ultimately metastasize to the neck. One of the reasons for why neck anatomy is of such clinical relevance, as mentioned at the beginning of this lecture. With respect to the ultimate drainage of the lymph back into the general circulation, however, I will ask you to review your lecture on the lymph from a year ago. Remember the general patterns presented then. Lymph from the right side of the head, the trunk, and the upper limb will drain to the right thoracic duct. The remaining lymph from the body will drain to the left thoracic duct. You dissected this during your thoracic dissection. And here's an image of a dissection of the left thoracic duct, delivering collected lymph back into the general circulation. The left thoracic duct travels on the right side of the posterior mediastinum, crosses over to the left side of the body, approximately at the level of the angle of Louis, and then makes its way into the root of the neck, where it will drain to a juncture where the left subclavian vein meets the left internal jugular vein. Thus, injuries to the root of the neck can also result in injuries to the thoracic duct. The right lymphatic duct drains to a similar spot on the right side, but it is smaller than the left and more difficult to dissect and see. We now move to discuss the last topic in the neck, the endocrine glands. In your physiology and pathology courses, you will hear more about the function that these organs play in our metabolism. Here, we will briefly mention their appearance, location, and blood supply. In this dissection, the strap muscles were reflected and the thyroid gland exposed. The thyroid gland is positioned below the thyroid cartilage and above the fifth tracheal ring. In over 40% of individuals, there is a pyramidal lobe, as present in this individual. Being an endocrine organ, the thyroid gland receives extensive arterial supply. Shown here is the superior thyroid artery, a branch from the external carotid artery. Recognize, however, that the thyroid gland will also receive blood supply from the thyrocervical trunk, a branch of the subclavian. And herein is the anatomical issue when thinking about this gland. If the gland needs to be excised due to disease, its extensive blood supply needs to be tied off, raising the possibility of causing extensive nerve damage. Additional surgical procedures also require knowledge of the blood supply to the thyroid gland. Tracheotomy, for example, performed in an operating room, is done below the location of the isthmus of the thyroid. To try and limit damaging blood vessels feeding the gland, although extensive hemorrhaging is sometimes unavoidable simply because of the extensive blood supply present. As an aside, having mentioned the procedure tracheotomy, do not confuse this procedure with cricothyrotomy. Both are made to keep the airway open. Tracheotomy, however, is not usually an emergency. The procedure requires full anesthetic and is ideal for temporary or permanent intubation. A cricothyrotomy, on the other hand, is a quick, relatively easy stab through the cricothyroid membrane. Anesthesia is not essential and is considered a life-saving procedure. Now, back to the neck. Just behind the thyroid gland resides the parathyroid glands, involved in calcium metabolism. They're difficult to see in a dissection, but in this specimen, I was able to find them. Note the inferior thyroid artery entering the thyroid gland, and notice its proximity to the recurrent laryngeal nerve. And to cement in your minds that thyroid surgery is generally not trivial, look at the drawings on the left, the formation of a goiter, and look at the image on the right, a goiter on an actual patient. Now imagine trying to find the blood supply to the thyroid gland that we have just discussed, while at the same time avoiding the numerous nerves of the neck, especially the ones associated with the superior and inferior thyroid arteries. This is not a trivial procedure. In this drawing, the relationship of the recurrent laryngeal nerve to the inferior thyroid artery is demonstrated. Imagine a thyroid goiter 4 or 5 times larger than shown and trying to perform the ligation of the blood vessel. In a subsequent lecture, we will discuss what happens if one recurrent laryngeal nerve is injured or if both recurrent laryngeal nerves are injured. Finally, I come to the last slide of my presentation, a horizontal section of the neck. We're looking at this section in the conventional orientation as if the patient were lying on their back. Note the important relationship of the trachea, part of the upper respiratory way, with the esophagus, part of the alimentary canal. This relationship is crucial in remembering when intubating a patient. I now end my brief but spectacular spectacular moment describing the neck. Hope you enjoy learning more about the neck.